Welcome back to Relational Lives. In 2025, there's been so much more awareness and diagnosis around ADHD. So today we have a psychiatrist, Dr. Graham Campbell, who's joined us, and we are going to answer that question and find out why. So, Graham, thank you for being with us today. We're going to kind of ask you some questions straight off, if that's all right.
Absolutely.
We have lots of questions.
We have lots of questions.
Great to be here.
One of the things I think people might want to know is what's the difference between a psychiatrist and a psychotherapist?
That's an interesting one, actually, because I often say that at the beginning of consultations when somebody's not seen a psychiatrist before.
Yeah.
So you could kind of say we're a bit like sort of psychotherapists, but with medicines. It's not really true because we're not really accredited therapists. We often have like some understanding of therapy, and some psychiatrists are trained in therapy, but really we're doctors with a sort of specialism in mental health, and we assess people mostly, I suppose, to give a sense of somebody's diagnosis and treatment options, and some of that might be psychotherapy. But
you can diagnose, we can't diagnose.
Yeah, we can prescribe drugs.
We can't.
Yeah.
So it's pretty clear then, I think.
Yes.
Yeah. Thank you. Okay. Go on then.
So, thank you. So, yes, what is ADHD?
What is ADHD? So ADHD it's a neurodevelopmental condition. So that means it's a condition that develops through your life and is kind of related to the development of your nervous system. So usually it starts, or you see signs of it before the age of 12. Mm-hmm. And a lot of times it kind of continues into adulthood. And I think some people say that it always does, but I think there are still some people who start to sort of not necessarily grow out of it, but grow around it and sort of don't have so much of the difficulty anymore.
Do you think that's because they've learned to adapt around it? Or?
Yeah, I don't think anyone sort of really knows, but I think, probably learning to adapt. I think there used to be an idea that your sort of nervous system developed perhaps a little bit more slowly in some ways, and then you sort of grow out of it, but mostly I think it's about adapting and finding different ways of coping, and maybe life circumstances change as well. But what it really involves is difficulty sort of managing attention. So that might be kind of difficulty sustaining attention, kind of holding your attention on one thing. Difficulty in not being distracted. Mm-hmm. So distractibility is a difficulty. Maybe listening to other people and staying on track. Might be forgetfulness, losing things, and then there's a sort of hyperactivity side where people can feel restless and have difficulty sitting still, maybe a bit impulsive as well, so difficulty kind of holding on to those impulses and not acting on them. So it's
when I was at school, a long time ago,
break into song.
Kids that were diagnosed with ADHD were seen as the sort of naughty ones.
Yeah.
The ones that couldn't sit still and they were naughty, and they'd be...
particularly boys, I think.
Particularly, but I don't remember any girls.
And I think that's perhaps a different presentation maybe, is there, in terms of boys and girls, and then I don't know whether there are changes into men and women.
Yeah. It's really interesting. So I have this conversation still quite a lot with people, that the threshold for diagnosis back then was so high and boys do tend to present differently to girls, perhaps a bit more sort of externalizing of their ADHD. They're more restless, maybe more disruptive in class,
So you see it more behaviourally.
You see it more behaviourally, absolutely. And I think there still are more young boys diagnosed than young girls.
Right.
Because of it being more obvious.
Because of it being more obvious, I think, yeah. So I often say to people that, we all carry around that sort of lay image, that sort of lay idea of what ADHD is. And when I meet people who got a diagnosis 20, 30 years ago, they tend to be the people that have the more severe ADHD. If we reassess them, they come out as severe. with lots and lots of symptoms. So, there are still people that present like that, of course, but there's so many other presentations.
And all those, I guess, would have been missed at that time, perhaps.
Yeah, because nobody really knew that ADHD was so prevalent, that it appeared in so many different ways and affected people in so many different ways. So loads of diagnoses missed, which can be really frustrating and for people, in a sense of almost a bit of grief, really, at kind of what could have been if they'd had it picked up, but then it wouldn't have been picked up because people just didn't know.
I think that's something I'm noticing with clients. Sometimes it's in adulthood, they're thinking, oh, maybe this has been ADHD all my life. I might have had this.
Yeah.
And there is, like you say, there's a bit of a grief around, God, if only I had known, or that something could have helped, because it can really have an impact, can't it?
Absolutely. And also just the experience of things slotting into place. And
making sense.
Absolutely. A real change in your sense of yourself and self-esteem.
That to me seems a really important element of people who want to go and for diagnosis, is the element of relief.
Yeah.
That it's not them all the times. I heard something on another podcast around, I think it was on ADHD, but with girls, and how many times they had been criticised by the age of 12. It was something like 20,000 times or something. Yeah. And you think, gosh, all those negative experiences that people go through.
Yeah, absolutely.
And then that relief of making sense of it, but like you say, the grief as well that comes in.
Yeah. I'm glad you brought that up, really. I mean, that's been, very recently in my clinic, I've had that kind of conversation that somebody was saying that, and they were female, that they were saying that, they just got so much criticism, often told to stop being silly and just, behave and
don't be so lazy.
Don't be so lazy. Yeah, all this negative stuff that comes at you because, you're behaving in a way that maybe is slightly outside the whatever we think of as normality.
What culture expects.
Absolutely. And sometimes that, obviously if you're a parent, that behaviour can be a bit more challenging and it can cause frustration for the parent, but that sort of criticism is really
and then
really
of course
difficult.
Not only have you got ADHD, but then you've got this negative view of yourself, haven't you? I'm a lazy person.
Yeah. Absolutely.
I'm not good enough.
Yeah. So
all those
common.
negative beliefs. Yeah,
it's so common.
It's so sad, isn't it, when just in a way, if there had been then more understanding and I mean, that's just what happens, isn't it? That it takes time for the understanding to come through. And
absolutely.
And what I wonder around is, it seems with people I come across that they're getting their diagnosis because they're recognising it now in their children. So often the child is seeming to, going for a diagnosis and then they're saying, oh, actually, this is very similar to me. I don't know whether you find that with people coming to you.
Yeah, I suppose there's been one situation recently where I've kind of wanted to speak to the parent of a young man, but speak to the parent about her diagnosis, and she hasn't mentioned it, but it's really, really clear, that she likely has a diagnosis too. I think there'll come a point where maybe, I will do that.
Yes.
I think it's, you kind of question whether that's the right thing as your patient is the young man, but
it's difficult, isn't it, though? Because some people, they really feel like they would benefit from a diagnosis, and other people feel like they don't really want that label.
No.
Yeah. People come in really ambivalent to the clinic about, whether to actually get a diagnosis, and sometimes even after getting a diagnosis, still don't really believe it, or there's a sort of overthinking and self-criticism as well. Like, am I just looking for an excuse? And
and then the people around them, I don't know whether you experience that in terms of the family around the person who has been diagnosed, and how that's, and friends or whatever, because they've known that person just as they are.
Absolutely.
And it can be, I think, often discounting. It's like, well, no, really, have you?
Absolutely.
And that again, I think adds to what you're saying, that negative kind of belief.
Absolutely. And I think the word label is just right, really. I think people often think that it's now a label that's going to be hanging around your neck and getting in the way of you progressing in life, and you'll just be singled out and stigmatized. But it's really not like that.
No.
It's actually I mean, everyone has an opinion. That's the challenge in society, that, you know, so many people have an opinion on ADHD, whether it's, you know, really positive or dismissive. But so I often say to people, like, just be, you know, cautious about your conversations, because initially, until you've let it percolate yourself, because, you know, you come across lots of people with strong opinions about this.
That's really good advice.
Yeah.
One of the things quite a few of our viewers, listeners have asked is, what does a diagnosis involve? What sort of questions get asked? How is that diagnosis made?
Yeah. So what we tend to do is a full psychiatric assessment, which is, it's meant to be an hour. I tend to run over often a little. So maybe sort of, 70, 75 minutes. And that usually involves, well, certainly, you know, in my clinic, a real full sense of that person as an individual, getting a real, you know, idea about where they're struggling, you know, what other mental health challenges they might be having. So really understanding the mental health history, physical health, medication, and family history as well. That's really, really important. You know, and so often I hear people say, you know, I say, do you have any other diagnoses of neurodiversity, autism or ADHD? And so often people say, not diagnosed.
Yeah.
Which, you know, is really interesting as well. And, you know, often we think about the diagnosed conditions, but, you know, you get a real sense that there's lots of people in the family who behave in the same way and have the same difficulties. And then a really important part of the psychiatric history is a personal history. So it's kind of like a life story, which is difficult to do in 10, 15 minutes, of course. But
we find this, I think, don't we, in our initial assessments with people, sort of gathering a whole sort of history takes time, doesn't it?
Absolutely. I often think of it as like, it's the peaks of the mountains, not the full mountain range.
Yes,
you know, just like the
nice way of
standout.
looking at it.
Absolutely. And that really gives you a sense of somebody's early development, what it was like to grow up as them, and their household and family relationships and school, university, and you know, all those kind of things. So we do that really just to see whether it's worth continuing with an assessment. You know, whether, you know, and in the private sector, of course, you know, it's not
expensive.
Cheap. It's expensive, and which is also interesting because people self-select. You know, I rarely see people who. I think this is an important point. I do rarely see people who. Well, I don't think I've ever seen someone come to my clinic who really doesn't have a need for, you know, some assessment. You know, and often when people do come to my clinic, like you say, it's after a lifetime of difficulty and genuine need. And even if sometimes, you know, I think actually this is more about an anxiety condition than ADHD. And sometimes the next part of the assessment, which is called the DIVA-5 assessment, which is often done by a psychologist or a specialist nurse at Flint Healthcare, you know, that might not show that somebody meets the full diagnostic criteria, but then there's still things to talk about, and there's still ways of helping. So if
they don't meet the full diagnostic criteria, but you're thinking there's still something that needs help, you know, something that could help here, what happens then?
So that could be anxiety or depression.
Okay.
Sometimes, you know, people have OCD, and that can also occur alongside ADHD as well. So there might be another mental health condition that is giving rise to some of the difficulties that person is having. Or it might just be that the person has a lot of traits of ADHD. And I think this is a really important point, that really we all have symptoms of ADHD or traits of Adhd.
Especially this day and age.
Yes. Social media.
It's so easy to get distracted, isn't it?
Absolutely. Absolutely. And I think one of the challenges of it, the diagnosis is that we can all relate you know, to it. And so some people say, oh, everyone's got ADHD these days. And it's like, not really true, because, you know, it's about how many of the traits you have, how many of the symptoms you have, how much it's impacting on your life, how much distress and difficulty functioning it's causing. And that's where the assessment is important. But yeah, we all forget things at times. We all lose things. You know, none of us, nobody is a machine. And I think we, you know, almost this day and age starting to compare ourselves with these kind of ultra efficient machines. But none of it, we're all imperfect human beings.
I think that's such an important point to make. Did you see that Chris Packham show?
Yeah, did you?
That was great, actually.
Yeah, it was really good. I loved
Yeah.
the way that guy used the metaphor of the tombola balls.
Yeah. It was really well done, wasn't it?
Yeah,
I really like what he's doing.
Hasn't seen it, it's on BBC iPlayer, I think.
Yeah.
Chris Packham on ADHD.
Yeah.
Yeah. That was a really great show because it didn't focus on, you know, neurobiology of medication, treatment. It really focused on a person's lived experience of ADHD and in the context of their family and friends.
And two very different examples with the two people they showed, wasn't it?
Yeah, absolutely.
Yeah, no, I thought it was really good.
And you mentioned earlier, I think the differences, differences between men and women.
Yes.
With ADHD, and I think one of the main differences, I think, is that women and girls tend to sort of internalize a lot of the restlessness and hyperactivity, and so they're more likely to not be sort of outwardly disruptive in class, but maybe chatting a lot in class, or daydreaming, or sort of being kind of in their own world, and as you know, as they grow up, it's more likely to develop difficulty regulating emotions, anxiety, and those kind of more internalized challenges than outward kind of aggressive behavior or irritability, hyperactivity in that sort of classic sense.
So quite different then between females and males.
Yeah. Of course, there is some overlap.
Of course.
But it's all about sort of, it's harder to pick up.
Do you think the same with adults, males and females, that it might be more sort of externalised behaviours that people notice? I
think it's still harder to pick up. It's still less obvious
in women.
So I think, you know, that does that different presentation. You know, it's further away from that sort of classic.
Yeah, the naughty presentation,
naughty boy kind of sort of narrative. So yeah, it's really interesting.
So go on.
Well, you mentioned about, you know, that show is not really about what's going on in the brain, but a lot of people are intrigued about what is actually happening in the brain and the neurochemicals. And we've had questions about cortisol, melatonin, dopamine, serotonin.
Okay, well, stop me if I start to go too deep. So it's really interesting. I think the science is still developing. You know, I think there might be a sort of impression that we now know everything we need to know about ADHD and what's happening in the brain. And even the dopamine hypothesis isn't quite as solid.
Okay,
that's interesting.
Yeah, I mean, you know, dopamine plays a role.
Just to be clear, what is the dopamine hypothesis?
Yeah, so the dopamine hypothesis is that it's just a lack of dopamine.
Yeah.
And that's the problem. And if we can just give people more dopamine, then things will be better, or kind of increase dopamine activity. And that's probably I think it is an oversimplification, a little bit like the serotonin hypothesis, that somehow you're just not having enough serotonin. And if you just give somebody more serotonin or get more serotonin, then everything will be better.
Yeah.
You know, that is an oversimplification of depression. There's a lot more going on. And so, you know, it's the dopamine idea is sometimes a pretty good shorthand, and it is relevant because the medicines we prescribe increase levels of dopamine or activity of dopamine circuits in the brain, and noradrenaline, which is another neurotransmitter. So it kind of fits in that sense, but it is more complicated, and good old neuroscience is horribly, exquisitely, wonderfully complicated.
Yeah.
So what's likely to be happening in the brain is that, I mean, you could imagine the brain if you can imagine a brain with having like a sort of bottom-up processing and top-down processing. The bottom-up processing is more what we think of as like a hot system in the brain that's a bit more emotional, a bit more sort of motivational, maybe a bit more impulsive. And then the top-down system is a bit more like the cool system, you know, like temperature-wise in a sense. It kind of is the area where you can really make sort of rational decisions, you can inhibit yourself, you can do the thing you're meant to do and not the thing you want to do.
So the sort of more evolved part, I guess.
Yeah.
Like the brakes as well.
Absolutely, yeah. So it's like the frontal cortex, and the parietal cortex, which is at the back, you know, this whole kind of top sort of outer layer of the brain. And you're right, it is mostly inhibitory. There's a lot of inhibition that's kind of keeping everything else in check. And it's kind of about the balance between those two networks. You know, if your cool system isn't quite working as efficiently as it could, then you're reacting to the world in a much more sort of emotional and impulsive and sort of quick way.
Yeah. Okay.
So
that's a good way of explaining it, I think.
Yeah, I often think of it, and anyone who's come to see me in clinic will hear me rattling on about airports and air traffic control towers. But
give us the metaphor.
Okay, so I think it's a fairly good analogy, but it's so the air traffic control tower in the airport, if that's a little bit like your frontal lobes, it's a bit like that cool top-down system. You know, that is there to sort of order the activity of the airport. Obviously, if it's not functioning, I try and imagine what's happening in the air traffic control tower. If people are asleep on the job, or you know, there's not enough staff and it's all going wrong, then the airport won't function. And then I start to think about like the people in the airport, what's going to be happening to them. You know, there's going to be overcrowding, there's going to be irritability, there's going to be loss of hope and despondence and people shouting, and you know, there's going to be a lot of disruption. And that, you know, that's obviously kind of a bit more like that hot, reactive, bottom-up part of the brain. So medication, when we give people medication, it's there to kind of try and improve the functioning of the air traffic control tower.
So what, bringing more of the cold effectively or cool in order to balance with the hot?
Absolutely, yeah. And so, to help that part of the brain work more efficiently, and, you know, I often think about the frustration that would be there in the airport if it wasn't working efficiently. So that's
not only that, but the planes would be crashing.
Yeah.
There would be chaos.
There would be absolute
there would
chaos.
be chaos. And people often talk about chaos, you know, in their lives. And that Chris Backham show really demonstrated that so well as well.
And I guess that's also where you're describing that, you know, we might all have things that we can relate to, but actually when you go into the actual diagnostic area of ADHD, that's where it's going to feel so different, isn't it?
Yeah, absolutely. You can think of it as a syndrome, really, where it's a whole cluster of experiences, and it's just how many of those you have and how much it's affecting your life. One person said to me in recent months, and I love this, he was a gamer, and he gave me permission to use what he said. But he said, you know, he's felt all his life like he's playing the game of life on difficulty setting hard.
Wow.
Yeah.
What a good way of putting it.
It's such a great way of putting it. That so many things that other people seem to do more effortlessly, and not, you know, obviously not everybody functions incredibly well, but he looks around him and thinks everyone else must be on easy setting. Yeah. You know, because why are the most basic things really, really hard? And
I think that must be really hard because people with ADHD are aware of that difference, aren't they?
Yeah.
They can see that difference, and so therefore questioning more about themselves. I think if you're in ignorance, in a way, you're just living in the space that you're in, aren't you? But when you know something, that must make it so much harder, I think.
Absolutely. And there's so many really smart and intelligent and, you know, skillful people with ADHD who are sort of held back in life by the difficulty of even, you know, of doing the stuff. And you can be an incredible artist, you know, with ADHD, but not sort of if you really struggle to kind of put your work out there and do the mundane stuff that it takes to.
Yeah.
Well, producer Paul has a diagnosis. I don't think he'll mind me sharing this. And he was saying about, that it can feel like a superpower in some respects.
Yeah.
And I've had somebody ask me, if I take medication, will it take away my superpower? Will it take away my creativity? Will it take away my hyper-focus? All these things that are really the good things about that. Yeah.
And that is a great point. So, I think it can. That's I think the simplest way of putting it.
Well, Paul was saying earlier, he notices that it does.
Yeah.
It can take away that creativity.
Absolutely. And I think, I often think about this, on social media you hear so much from people who are motivated enough to sing the praises of their medication. There might be the people in the top 20-30% who have a radical improvement, and everything's, from the social media posts, everything's suddenly better and they're normal again and everything's great. But some people, do struggle with medication, and it doesn't either. There's a sort of inadequate effect, and actually, it is fair to say, and I've got another analogy that I go on about, which is that medication is a little bit. I don't want to lose the point, but I'm going to go off on tangents. Medication is like the electric motor on an electric bike. It helps, but you've still got to pedal and you've still got to ride the bike, unless it's one of those unregulated ones that people ride in London, where you can just press a button and go 50 miles an hour. But no, normal electric bikes are pedal assist, and the motor helps you function. But you still have to ride the bike, and you still have ADHD, and so managing expectation around medication is really important. But coming back to the point about, can it take away your superpowers? I think so much of that is about finding the right medication, finding the right dose, and that's why it's usually not as simple as, right, get a diagnosis, take medication, and everything's fine. So it can take a little bit of time, to fine tune it. I've worked with people who have had medication before, even when they were younger, and they say that it kind of numbs them, it kind of makes them feel a bit like a zombie, or blunts their personality, and it really can do that, because a stimulant kind of can turn your sort of lantern awareness of attention of things all around you and picking up details and things around you into this kind of focused torchlight consciousness, where you're much more task orientated and driven to do stuff, but you're not
as creative.
Might not be as creative. Your mind might not be going off on all the interesting, creative.
It's such a lovely part of that, isn't it? The fact that the mind can just ping off and just come up with different ideas and
absolutely.
And with the medication, you said that there are a number of different medications, and also I believe one of the things I've heard is how, unlike other medications, it can be a very instant experience for people. But also, is there, depending on the type of medication, is there an element of choice, so that you can then balance it with times you don't want to take it and times you do, in order to have that kind of days of creativity or whatever? I don't know. I mean, I don't know whether that's
a question.
There's so much I could say. So again, stop me if I go on too long. Choice, I think, is super important. When it comes to working with people with ADHD, it's very co-created, and it's very, very much a sort of patient-centered approach. We try and work out with the person what's going to be best for them, and if you don't get on with stimulants, and usually stimulants are the first line treatment, because there's evidence that they work really well. But if you don't get on with that, then there's non-stimulant options. If you don't get on with taking a long-acting stimulant every day and having that effect, for most of the day, then you can take a short-acting version, so that if you really need to do something, you can have
Be focused for a certain amount of time.
Absolutely.
Yeah.
But then you don't have to spend the whole time, with being medicated. But usually, again, that's a bit of a process of discovery. And you kind of need to sort of trial the medication often to know what's right for you. And people come in often saying, well, I've heard great things about this medicine from a friend, and you might start that medicine, but it's not the right one for the individual.
So it's very personal.
It's a very personal thing.
And do you have to, when you prescribe medication, do you have to do an element of strategies with that person, bearing in mind they have ADHD, to be able to remember to take their medication if they choose to do that?
Yeah, absolutely. And that's the downside of the short-acting medicine, because sometimes people need to take a booster dose after a long-acting medicine just to keep it working into the evening or late afternoon when they still need it. But so often, people can forget to take it. And that's where the benefit of just taking it in the morning, comes in. So it's really working with the person to find the right thing for them in their life and in their situation in their life and, what they're doing.
Because one of the things I've heard that people find really frustrating when they're pretty sure they've got ADHD, they might not have the money to come to see somebody like you. They're on probably a very long waiting list with the NHS. They are then asked to make certain appointments or do certain things or fill out certain online forms. And by the very nature of their wiring, they find it so hard. It seems like there are obstacles that aren't particularly ADHD person-centred.
No, absolutely.
I don't know what your experience is around.
I mean, absolutely that. I think even just making an appointment with a doctor when it is challenging, so even just see a GP sometimes. That is hard. And I mean, we see it in the clinic sometimes that, people forget appointments and run out of medication and then, get into a pickle with that. And it just all these kind of sort of mundane admin tasks are just so much more difficult.
It's like everybody needs a PA really, don't they, in a way?
Absolutely.
It's like if there's a possibility, I think that with people who have all this creativity, who have these, amazing ADHD minds and, could sort of do an incredible business, but they sort of need a team around them in order to make that kind of happen. And
so is that the cool part of the brain you're talking about? Is that would normally be going, oh, come on, we need to do this boring task?
Absolutely.
Yeah.
That's
come on, even though it's boring, come on, let's just do it.
Absolutely. That's the part
that
out
of the way.
Yeah, that's necessary, that's practical, or that's rational to just do and get out of the way and done.
Yeah.
And then I've got the whole weekend ahead of me, that kind
delayed gratification type
Absolutely. Yeah. There's a concept called effortful control, which is essentially that. It's essentially kind of how, when you know the right thing to do or the thing that's going to be most beneficial to you, but it's boring as hell. How do you do that? And can you do that? Can you sort of manage all that stuff?
Because again, probably most of us have times when we struggle with that. Oh God, I don't want to do that boring task.
Absolutely.
Let's just
that is a
forget
normal,
about that.
Yes.
Absolutely, that's a normal human thing as well.
But I guess the difference is that we somehow at some point are able to do it. We don't have to necessarily have the thing, I guess, at the other end to think, although that's nice. Delayed gratification, I think, is great.
No, absolutely. The other thing I was going to say was just that, obviously we've gone into talking about medication, but that's got to be part of a sort of, I don't like the word package because, it's rarely actually a package, but it's got to be part of the plan, really. So often we talk with people about all the other things they can do with exercise, healthy eating and sleep.
Okay.
I consider all of those things to be medicine as well. And, biological psychiatry often gets a bad name for just being reductionist and biological, but all of those things are biological. They really...
Of course.
A lot of people find exercise really helpful, I think.
Yeah.
People with ADHD.
Absolutely. Yeah. And I was going to say that there can be the pleasure of doing it, but often for people it's not pleasurable to go to the gym or to go for a run, or it's a hard thing to do. But so there is that, but then the biological benefits in the connectivity of your brain, is so important.
So it seems like that, lots of people say, well, everybody's being diagnosed with ADHD now. Do you have any understanding as to why it seems more in the arena of people's awareness now?
Yeah.
And whether are there more people being diagnosed? What's happening in terms of that?
Yeah. So there are more people being diagnosed. When I've heard the Royal College of Psychiatry and various kind of authorities on ADHD, people and researchers talking about the fact that still there's only a fraction of the people that have ADHD that are diagnosed, and the UK is catching up with other parts of the world
I heard that.
in recognising it. Social media, of course, plays a role. Like, there's a lot of attention, awareness raising. Sometimes, I do see social media stuff that I sometimes it does make it. They talk about isolated traits or symptoms of ADHD, and again, as we were talking about, it's if you do this, you might have ADHD, and again, there are things that really do relate to so many people. So there is a risk with some social media that it kind of gives the impression, well, everyone's going to have ADHD. But I think it is important that we know about it. But certainly, there's an increase in diagnoses, and that is, I suppose it's appropriate, because there are so many people that are still struggling, and it's really important because it's related so often to other mental health conditions, like depression and anxiety. And I've certainly worked with people who, have lived with depression and anxiety or emotional instability or drug and alcohol problems or what's often thought of as kind of antisocial behavior, difficulty in relationships, all of these things, or really severe rejection sensitivity, dysphoria, which is an interesting one because, who likes rejection? But it can be, incredibly intense for people.
Can you say a little bit about that for people who might not know about rejection sensitivity dysphoria?
Yeah. So,
because it can be quite combined sometimes, I believe, can't it, with ADHD?
Absolutely. So it really is, a kind of feeling really, really terrible when there's any sense that somebody is rejecting you or invalidating you or, criticizing you, and that you're being kind of rejected or shunned. And sometimes that can be, real sensitivity or hypervigilance to that, and or any sense that you're not being included or being rejected. So, and again, who likes that? It's always going to be upsetting and difficult. But some people can move on a bit easier or don't go into such a spiral of despair or anxiety when that happens.
I guess maybe that makes sense of what you're saying about those two different parts of the brain as well, the hot and the cool, that the hot is going to be that like reactive I'm being rejected. And if we've got enough cool, we can say, okay, I'm not necessarily being rejected.
Yeah. Absolutely.
Whereas if you haven't got that, you're just in it, that horrible feeling of...
Yeah. It makes me think of CBT, I suppose. And CBT is sometimes has been used for ADHD, and for some people I think can still be helpful, but is increasingly recognised as an approach that is quite challenging for ADHD, people with ADHD, because it does rely on that kind of rationality and the cognitive side, and that cool system being able to work to think through the pros and cons or the for and against for a situation and what might be happening. So a lot of people with ADHD just really find CBT really, really difficult. Another therapy approach, that can be really helpful is DBT.
We were saying about that, weren't we?
Yeah, and I think DBT, as far as I understand it, and I'm not an expert in DBT, it really helps people to kind of manage the intensity of their feelings and
so more soothing. Coming in, perhaps.
Absolutely, yeah. So it's sort of understanding the intensity of their feelings and kind of finding a way of having acceptance, and for that to sort of be validated as well. But at the same time, finding new ways to kind of work with it, new new ways to express it, more kind of often, maybe more healthy and safe, ways to kind of manage.
I think one of the things I was wondering about the rejection sensitivity, so we're talking about that in the brain, but also if someone's grown up with that feeling of they're just lazy, they're not good enough, that on top of the rejection sensitivity in the brain, it's just going to be excruciating, isn't it?
Yeah.
In my experience, that's the rejection sensitivity part is the hardest part.
Yeah. Yeah.
I mean, I'm not saying that other parts aren't hard too, but that seems, and I don't
in your experience
of
with
people working with people with rejection sensitivity dysphoria, that element of their ADHD is the thing they find the hardest, they struggle with the most.
Yeah.
And it seems, and I don't know about whether the meds can have any impact on that, and like you said, the DBT element, maybe finding ways in which people can relate, sort of soothe their systems more. But it seems so hard to do anything different in the moment when they are feeling that rejection.
Absolutely. Often because the emotions can be so overwhelming.
Yeah.
And, I've often thought about this in my role as a psychiatrist over the years, that when your emotions are intense, it gets in the way of thinking. Kind of, whether that is, extreme kind of sadness or anger. Anger's a big one that just stops you thinking.
Sure.
And so that emotional intensity can really make it really, really difficult to think rationally about a situation and to get through it. And often the rejection sensitivity dysphoria can lead people to go to extra lengths to please others, to avoid any kind of rejection, to be included, to be validated, which, sometimes that can also contribute to the problem.
Yeah, and such a vicious cycle, isn't
absolutely. it? Absolutely, and make that person more vulnerable to it. So that people-pleasing side, it takes so much effort, and it's so, it's like a strategy that takes so much energy and effort, but it's kind of essential for that person to avoid that awful feeling of rejection.
Yeah.
And it can, so medication can help with that.
Okay.
I sometimes have patients asking me, well, isn't this medicine better for rejection sensitivity? And I don't know that you'll always find someone's opinion or some paper or something on the internet that backs up these things. But in general, a medicine that kind of helps, and I don't like computer analogies, but bring online that cool part of your brain, that top-down system, that sort of ability to kind of think a bit more rationally. That can really help, as you're describing, just to be able to think around a situation and to
get a slightly different perspective.
Absolutely. I've seen that, and people kind of say, actually, I'm a little bit better with my boundaries.
Okay.
So it can really, really help, and relationships can improve, and people can sort of have better conversations with a partner, or actually inhibit that they don't fly off the handle as much, or don't spiral into despair and have to leave the situation, but sometimes can actually talk about things a little bit easier when they're
That's one
medicine.
of the other questions we've had, isn't it, about relationships? But I don't know, we're probably well placed to answer that one in terms of what we see with couples, but it certainly impacts relationships, doesn't it?
Yeah. And can I ask you a question? Because I'm really keen to know. Have you worked with people who have got a diagnosis and started treatment while they're seeing you?
Yes.
Yeah.
And do you notice changes in the therapy
when they're medicated?
Yeah.
Yes.
Ah, okay. What do you notice? If I can turn the tables.
Well, I'm thinking, that sometimes I think that the client is aware of the difference and how they describe it, and what I would be doing is asking them more. I notice a difference, but they notice it in so much as if, for instance, the hyperactivity is not necessarily an external one, but an internal one in their minds, and they're buzzing around, that there is more of an ability to be able to hold on to a question that they want to ask or something that they want to say, or be able to listen to the interaction between us differently. And there is certainly, I think, for me, my experience of working with a number of people is that there is more of a focus, and perhaps not necessarily always calmer, but something slightly different in the feeling between us. So sort of more calmer, but I think it's the calmer with more focus.
More presence, I think.
Yeah, more presence.
More
that's a good way
ability
of putting
to
it.
stay present with what's happening or listening.
Yeah, rather than going off.
If it's a couple as well, that they're able to listen more.
Yeah, it's really interesting. I've had people say that sometimes, and it's not in every case, of course, but people say that they're just a bit more aware of the dynamics in their life. They're a bit more aware of the things that they've done that haven't been helpful. You know, there's just a sort of greater awareness. And occasionally people say, actually, probably ignorance was a bit better, you know, not being so aware of all of the stuff. But, you know, so I've often wondered, can it make psychotherapy a little bit more effective or productive, or, you know? Yeah,
I think also with, we both trained also in EMDR, eye movement desensitization reprocessing, for anybody who doesn't know, but I think that can also be helpful in terms of the meds. I don't know whether you've experienced that, Ali.
I'm trying to think if I've got anyone.
But certainly I've found that when people are medicated, it can help with that approach. People being slightly more because of the nature of EMDR and the fact that the mind can go off.
It's not going off so much.
Yeah, it's not going off quite so
yeah.
Yeah,
makes sense.
So it's quite interesting.
Just so we make sure we ask
I was just going to ask about people who don't have money and they feel like they think that they've got sort of likely ADHD possibility diagnosis. What would you recommend that they do in order to go down the path of diagnosis? Yeah,
I would say try not to delay too long speaking to your GP.
Okay.
Because there are, to my understanding, 2 different waiting lists. So there is an NHS service that's kind of within the NHS that is massively oversubscribed, and you know there can be incredibly long waiting lists, but there is the right to choose pathway.
Okay.
And
can you say a little bit more about that? This is again for people in the UK.
Yeah, and not working in primary care, you know, I want to just have that caveat. So, but I, from my understanding of it, that the right to choose, if you say, I'd like to go down the right to choose pathway to a GP, then there are other private companies that work with the NHS and are kind of associated with the NHS who do a lot of these assessments, and you might, within a shorter space of time, be able to get an assessment, and that might be it's usually an online assessment, and that will kind of give you an indication of whether you have ADHD or not. There's a sort of that diagnostic assessment. I think from what I've heard people say that you do then have to wait a bit longer to get onto a treatment waiting list. So it can still take some time, and it can, as far as people tell me, and it varies across the country, I think, and I work with people, across the country, as well as in Brighton and Hove and in Sussex. But I think it can still take, 18 months, 2 years maybe.
It's a long time, isn't it?
Which is a long time. Yeah. And it's such a long time that it puts people off even starting the process. But the sooner you start the process, it'll come round. But
and is that different in terms of adult and child? If it were a child that a parent is concerned about, is it the same route?
Oh, that's a really good question. The first thing that pops into my mind is the difficulties in child and adolescent mental health services, that there's such a delay and such a high threshold for getting the appointments.
This.
Yeah. Not that I would dissuade people from still speaking to their GP, and, you know, trying to get a service, because I think that's really important. But yeah, I think sometimes there's, you know, it's still the private sector that people go to.
Yeah, they have to save up and try and...
Yeah.
It's so hard, isn't it?
It's really hard.
I mean, I appreciate you're in it, but it's so hard for those who...
Yeah, absolutely.
Can't.
Absolutely.
You know,
Well,
this is one of the reasons we do this, isn't it?
Yeah.
It's so important to put some stuff out.
Because sometimes it's helpful just people to have information like this, isn't it?
Really helpful.
yeah.
To understand it better, to know what could help.
Yeah. And there's a lot of self-rating scales, you know, that people can use. And obviously they don't give you a diagnosis.
No.
They're a screen, you know, they kind of help you to at least look into it for yourself.
Are there any that you'd recommend? Because obviously there are quite a lot out there that people might think which is a reputable one to look at.
So the best one is the ASRS.
ASRS.
So
We could put it in the notes, couldn't
Yeah.
we?
I think it is actually just the ADHD self-rating scale.
Okay.
It's good to get the most modern version, which I can't remember which version that is. But that kind of goes through all the a lot of the symptoms. And obviously the most important thing to do is really think deeply, really think about the answers you give and just really how much those things impact on your life. Because again, you know, you can relate to probably all of them to some degree. But
one of the things though that people can do is overthink it then, isn't it?
oh yeah.
You know, you're looking at the question, am I on? And then think about it too much and then
Yeah.
it's a tricky one.
Yeah, but yeah, I mean, working in the private sector has only been like a small part of my career. I worked in the NHS for the majority of the time, and still really aligned with the values of the NHS, and just wish the NHS had
more resources
and more resources to be able to
I'm with you
do this. And there's been a lot of work actually recently in the Royal College of Psychiatry to help general adult psychiatrists and teams within the sort of usual secondary care mental health services to look out for ADHD and to feel more confident in diagnosing.
Okay.
And although there's still some limitation, you know, there, but I think there are efforts to try and make it not just specialist services and that are doing these assessments, because, you know,
it's going to take forever to get through otherwise, isn't
absolutely. And so many people with mental health problems have some degree of neurodiversity, whether that's ADHD or autism.
Yeah.
So
so important, isn't it?
absolutely.
Well, we've come to we're bringing in a new segment, aren't we?
We are
Of
bringing
our
in a new
podcast.
segment.
A
You're
fun
our
segment.
first.
Oh
You're
my
our
goodness.
first person who's
It's
going to experience this.
just
Okay.
3 fun, quick questions for you.
Okay.
Quick fire. Coffee or tea?
Oh, it has to be coffee, but I know I should be drinking more tea.
Why?
Because, tea doesn't have quite as much caffeine, and caffeine isn't always the greatest thing. But I love coffee, and I can't stop drinking coffee.
How many cups do you have a day?
I have to be careful, because, you know, I can get sort of overstimulated with it. But I think I'd say 2 good coffees a day.
Okay.
Yeah.
Okay.
But
that's okay.
Yeah.
We'll allow that.
Absolutely. When I was working in the NHS, when I was working my previous job, if I had more than that, by the end of the week, my shoulders would be like rocks.
Really? Gosh. So you really noticed a difference?
Absolutely. Yeah. I'm sensitive to it. So I have to kind of keep it low.
We'll do the next one.
What's our next one? Beach or forest?
Forest. Mm-hmm. Yeah, definitely forest. Yeah, I'm not massively into the beach.
Mm-hmm.
Don't know what it is.
What do you get from a forest? You sounded almost a little bit calmer when you said it.
Well, that's it. Yeah. I think a forest is it's so much calmer. It's I love the quietness in a forest, the change in the sound around me. It's sort of, I'm imagining the sort of, is it petrichor, that sort of smell of rain, that damp smell?
And I know what you mean, but I don't know the word.
Yeah, I think the forest is much more peaceful. That was an instant thing.
Morning or evening?
Well, I'd say evening.
Okay.
Yeah, I've always been an evening
You're a
person.
night owl.
Yeah, definitely. I've been forcing myself more recently to try and be a more morning person. And I do think there's a lot to be said for the morning. Like, I love it when I do wake up before everybody else and it's quiet and, you know.
But naturally you're a
dreaming
more
time.
evening person.
Yeah, naturally much more evening. If left to my own devices, I would just gradually start going to bed at like 1, 2, 3, and just, you know, but I can't do that. It's not really conducive to
to a working day.
No, absolutely. Yeah.
Thank you so much
Yes,
for coming
thank
on.
you.
It's been amazing. Yeah.
Well, you can carry on if you want, but no, you've given us so much time already, and it's going to be so useful for people who are listening. So thank you so much.
It's been a real pleasure. Thanks.
Oh, and we need to just say about Flint Health, is it?
Flint Healthcare.
Yes,
yeah.
do you want to just say a little tiny bit where you are?
Okay.
And
yeah, so we're on the outskirts of Brighton, a small clinic in Woodingdean. So it's like a business park, great views over the downs.
Oh, lovely. This is in the UK, everybody.
In the UK,
yes.
Absolutely. So the clinic it was set up just over 2 years ago by colleagues, one of whom I worked with in the NHS, and they've worked in the private sector. So they set up this clinic to provide general adult mental health services. We do see some people who are 16, 17 years old for ADHD assessments because you know that's really important for that age group, and we do neurodiversity assessments as well, ADHD, autism. So a whole lot of different things.
Excellent. Thank you. Well, we'll put the link in our show notes.
Great.
So that people who can afford to come along might want to get in touch.
Thank you for watching, everybody.
Yes, thank you.